Hi, everyone. We will get started in just a couple minutes. Wait for everybody to get on and get started at the top of the hour. I'm sorry, at the half hour. Okay, welcome everyone. I'm going to go ahead and get us started today. Welcome to our final installment of the Southwest Stroke Committee's summer webinar series. My name is Allison Capetillo, and I'm going to be your moderator today. Before we get started, I'd like to go over a few housekeeping items. During the presentation, please feel free to enter your questions into the chat box. We will have time for Q&A at the end of the call. Following today's webinar, we will be sharing the slides, recording, and a completion certificate. These will be available to you in the next 2 weeks, so please keep an eye on your email for those items. So without further ado, I'd like to go ahead and get started and introduce our speaker, Dr. David Wheeler. Dr. Wheeler grew up in Missoula, Montana, and as the son of educators, he developed a love of learning and passion for making a difference. During college, he discovered a strong interest in cellular physiology, which led him to contemplate a career in medical research. He spent two importantly formative years at Oxford University, completing a master's in physiology, studying neurotransmitter systems in the basal ganglia. After his time at Oxford, Dr. Wheeler then moved to Stanford, where he spent 9 years obtaining his MD and PhD in neurosciences. His research focused on the role of calcium channels in controlling synaptic functions in the hippocampus, processes critical in both mechanisms of learning and epilepsy, thereby forming the basis of what would become his major neurologic interests. During his final years of medical school, he found that he greatly enjoyed patient interactions and decided to start moving away from the bench research toward a career in clinical medicine. He left the Bay Area in 2000 and moved to Boston, where he spent 5 years in hospitals associated with Harvard Medical School. He received outstanding clinical training in general medicine, neurology, and epilepsy, and has also had very extensive experience in inpatient stroke care. Central to his decision to move to Casper, Wyoming, was the opportunity to help develop much-needed neurology programs from the ground up. He's been very busy in the years since he came to Wyoming and growing his general neurology and neurohealth practice. He established the Wyoming Epilepsy Center, which provides comprehensive care to thousands of Wyomingites affected by seizures. He's also been a leader in the development of our nationally recognized primary stroke center, with a keen interest in stroke systems of care tailored to the rural environment. He's an active participant in several local, state, and national programs devoted to system improvement and delivery of excellent care. He has also been very active in hospital leadership positions and enjoys a variety of opportunities to teach residents, medical students, MPA students, and nurses in the office and at the hospital. So without further ado, I'd like to introduce Dr. Wheeler in his presentation today, Pre-Hospital Processes, Stroke Training for EMS Professionals. Dr. Wheeler, the floor is yours.
Thank you. Remind me to send you a briefer bio next time.
It was a great bio.
This is a really great opportunity to talk to you folks about one of the things that made the biggest difference in our ability to treat patients in a timely fashion in our rural stroke system of care, and that is improving the pre-hospital systems and pre-hospital notification. And the value of this kind of work in rural settings really can't be overstated, and has been an important part of the work that American Heart Association, American Stroke Association have done over the last couple of years to really try to identify how to better deliver stroke and heart attack care in rural settings. And so I'm very happy to finally get a chance to talk to all of you about pre-hospital systems, and especially how to train our EMS colleagues to be especially important participants in the stroke system of care. So the course objectives are to learn about stroke. We obviously have a diverse audience today, so we'll start from the ground up. We'll review some of the newer policy recommendations from American Heart Association and others about systems of care for stroke. We'll discuss some of the new stroke protocols and hospital care that's evolved in recent years that are improving stroke outcomes. We're going to look at some of the stroke assessment and stroke severity tools that are available and in use, and talk about the impact that can have on pre-hospital care. We'll highlight the value of pre-notification to activate the code stroke process for the hospital. And finally, we'll do a broad overview of stroke treatment in its current state. So let's learn a little bit about stroke. Obviously, stroke is an important medical problem that while we have new and rapidly advancing treatments, is not a problem that's going away. Stroke treatment is effective, but only if the person gets to the hospital in time to take advantage of it, and if that hospital has made the appropriate systems improvements to be able to provide that care in a timely fashion. And the EMS providers within any given region play a critical role in making sure that acute stroke patients are able to access these new and evolving treatments. Stroke or brain attack is a medical emergency and happens when there's a loss of blood flow to some region of the brain. There are nearly 800,000 new strokes in the United States every year, and it is currently the 5th leading cause of death in the United States. It is also, at the same time, the leading cause of long-term disability in adults. With the new stroke happening every 40 seconds, and it's critically important that we work together to develop systems of care to make sure that every person in the United States has access in a timely fashion to the best available care. That treatment is very time sensitive, as we lose nearly 2 million brain cells during each minute that a large vessel occlusion stroke goes untreated. With almost 8 million stroke survivors in the United States, the ongoing cost of stroke care and stroke burden on the United States exceeds $53 billion as of 4 years ago each year. Stroke affects all ages, all racial and ethnic groups, all socioeconomic groups. It is a universal problem, and one which requires our diligent efforts to address. There are different types of stroke. Most of the treatments we'll talk about today focus on diagnosis and management of ischemic stroke. An ischemic stroke happens when there's an interruption of blood flow in an artery to the part of the brain, and this accounts for nearly 90% of all strokes. The two main categories of ischemic stroke are those caused by blood clots or chunks of cholesterol plaque that travel from outside of the brain, typically the heart or the aorta, or sometimes the carotid arteries, and then travels up into the brain, occludes blood flow in an artery, and then that part of the brain starts to die. There are also thrombotic strokes that are caused by blood clots that form inside an artery in the brain itself. So embolic versus thrombotic strokes. A stroke that's caused by occlusion of a large vessel, such as the carotid artery or the middle cerebral artery, is referred to as a large vessel occlusion, or LVO stroke. These are typically the most serious stroke presentations. And this is the type of stroke for which new advanced care modalities are available. And so it's very important that we be able to recognize these large vessel occlusion strokes, and that our systems of care be set up in order to make sure that people presenting with an LVO have the opportunity to get that more aggressive care. Hemorrhagic strokes account for about 10% of strokes overall, and these are caused usually by the rupture of a blood vessel inside of the brain itself, leading to a hematoma inside the brain, which can expand and cause damage to the brain around it, as well as loss of blood flow to the brain from the ruptured blood vessel itself. They can also be caused by ruptured aneurysms, which cause blood to escape from the arteries onto the surface of the brain. So an intracerebral hemorrhage caused by rupture of a blood vessel in the brain versus a subarachnoid hemorrhage, which is caused when an aneurysm outside of the brain ruptures. The clinical presentations and treatment for these two different strokes are quite different. And finally, I want to mention the transient ischemic attack, or TIA, which used to be referred to as a mini stroke. A TIA causes a stroke-like presentation, but typically the blockage or the cause of the stroke goes away on its own, and typically no permanent damage occurs. Most TIAs last less than 1 hour and don't cause any visible changes on subsequent brain imaging. However, a TIA is an important warning sign that a stroke may be impending. So about 7% of TIA patients have a stroke within 90 days. And if you can flip that around and understand that about 1 in 5 patients who've had a stroke had a TIA within the 48 hours previous to their presentation. And so a TIA is definitely a medical emergency. It's very important that these folks be taken to the emergency department. And while they may not get emergency treatment, they will get an expedited workup to try to figure out why they had a TIA and make appropriate changes to their treatment to lower their risk of a stroke happening in the near future. So let's talk about what stroke looks like. When a stroke happens on the right side of the brain, some of the common symptoms that we see are slurred speech. So that person may be able to understand, may be able to even make themselves understood, but their speech is typically thick or slurred. They typically will have weakness or sensory changes on the left side of the face, arm, and or leg. They may have difficulty paying attention to the left side of their body. So this is the neglect syndrome. And sometimes when the stroke is very severe, their eyes will be forced to the right. So their gaze will be deviated away from the side of their weakness. By contrast, a stroke in the left side of the brain will typically cause most people to have difficulty speaking or understanding speech. So they may have aphasia with difficulty with comprehension. They will develop weakness or sensory changes on the right side of the face, arm, and or leg. And their eyes may be deviated to the left, again, away from the side of the weakness. A stroke in the brainstem can be a little bit harder to recognize because it causes symptoms that can mimic or look like many other causes of acute brain dysfunction. But some of the typical things that we see include nausea and vomiting, room spinning dizziness or vertigo, speech problems, usually in the form of slurred speech or dysarthria, problems swallowing or dysphagia, abnormal eye movements, often with eyes pointed in different directions or unable to track smoothly together. These patients often have a decreased level of consciousness, and they may have what we refer to as crossed findings, which can mean either weakness on both sides of the body, or even sometimes weakness on one side of the face and the other side of the body. Hemorrhagic strokes typically present with symptoms such as nausea and vomiting, severe headache, weakness on the side opposite from where the hemorrhage has occurred, and they will often present with a decreased level of consciousness. One more tidbit I would add here is that hemorrhagic strokes sometimes present a little bit less abruptly than an ischemic stroke. So in an ischemic stroke, all of the symptoms hit the patient almost all at once. Whereas in a hemorrhagic stroke, the symptoms may develop over several minutes and get worse over the course of the next minutes to hours. A subarachnoid stroke, a different kind of intracerebral hemorrhage caused by a ruptured aneurysm, typically will cause what the person describes as the worst headache of their life, or a thunderclap headache. These people will have sensitivity to light, and they'll develop stiffness of the neck, and they can look very much like they have meningitis or encephalitis. And this leads me to a discussion of some of the things that look like strokes but are not. And some of the common things that we see in emergency departments that end up not being strokes are intoxication with alcohol, infection of the brain or the meninges, so meningitis or encephalitis, an overdose or toxic effect either of prescription medications or recreational drugs, a rapidly expanding blood clot on just outside of the brain but inside of the skull called an epidural hematoma. Severely low blood sugar can cause symptoms that look exactly like stroke, and so too can disorders caused by malfunction of the liver or kidney or other metabolic disorders. Migraine headaches are a very common stroke mimic, with people presenting with complete weakness on one side of the body or difficulty speaking or numbness of the face or arm. All symptoms that we typically associate with stroke can also be seen with migraine presentation. Some folks can have peripheral nerve disorders that affect parts of the body, especially one side of the face, in a condition called Bell's palsy, which can look a little bit like stroke. People who've had seizure, have recently had a seizure and have not yet recovered from it, may present as if they've had a stroke. This is called Todd's paralysis and may cause one side of the body to be completely paralyzed for minutes to hours after the seizure occurred. Brain tumors can cause a person to look as if they've had a stroke. And then finally, very severely elevated blood pressure can cause a condition called hypertensive encephalopathy, which also can present with signs and symptoms very similar to stroke. And obviously, in each of these disorders, the treatment, the way to help this person get better would be very different from our treatments from stroke. And so it's very important that anybody with symptoms concerning for stroke get quickly to a stroke center so that we can determine whether the condition is caused by stroke, and if so, ischemic or hemorrhagic, and if not, is it one of these stroke mimics that may be treated differently? So let's talk about treatment of stroke. And as I mentioned, the talk from here on out will focus mostly on management of ischemic stroke. So when a patient arrives in the emergency department with signs and symptoms concerning for stroke, one moment. Need to move the picture out of the way so I can see better. There we go. So when a patient arrives in the emergency department with signs and symptoms concerning for stroke, one of the most important considerations is, when did the stroke start? So if the symptoms started less than 3 hours from presentation and they don't have another contraindication, most patients will be eligible for treatment with thrombolytics, that is alteplase or IV TPA, or in some centers are starting to use tenecteplase or TNK. Many patients may be eligible for an expansion of that window for treatment up to 4.5 hours. And some of the ways we decide whether that would be safe or not is if the patient is less than 80 years old and has not had both a history of stroke and diabetes. So in those cases, if none of those things are true, that patient may be eligible for thrombolytic therapy up to 4.5 hours. If their symptoms were greater than 4.5 hours, but clearly consistent with stroke, we need to consider treatments other than thrombolytics, which we'll talk about in a minute. If they are eligible for thrombolytics, then the most important diagnostic test is brain imaging, which in most stroke centers will be a CT or CAT scan, mostly to rule out hemorrhage or intracerebral hemorrhage or other non-stroke causes of their symptoms. And if that CT scan shows no other obvious explanation, then the goal is to start IV thrombolytic therapy as quickly as possible, with high-performing stroke centers doing this often within 20 minutes of arrival to the emergency department. And again, whether or not they are a candidate for thrombolytics, if they have signs and symptoms of a severe stroke for which advanced treatments may be possible, then these treatments should be considered. So the medical management of ischemic stroke is IV thrombolytics. The most commonly used is TPA or alteplase, with many centers now adopting the use of tenecteplase or TNK with similar inclusion and exclusion criteria. And this is a clot-busting drug, so it activates enzymes in our bodies which naturally destroy clot. And the sooner that that's given, the greater the probability the patient will have a good outcome. So the standard window is up to 3 hours from symptom onset, with an expansion of the window appropriate for eligible patients who are under the age of 80 and who have not had a previous stroke or have diabetes. And there are other contraindications which you can review in a variety of locations. Another form of treatment for acute stroke is mechanical thrombectomy, which may be offered to selected patients who present with large vessel or LVO stroke, large vessel occlusion or LVO strokes. This is performed using a device called a stent retriever, which you can see on the right side of the screen. The time window for mechanical thrombectomy may be as long as 24 hours from symptom onset, but, and this is a critically important piece of advice, just because the window is long does not mean that you should take your time deciding whether to move forward. We're still losing, and especially in these patients, we're losing 1.9 million brain cells per minute. And the earlier the intervention is successfully performed, the greater the probability the patient will have an excellent outcome. And so time is brain in every case, even though the time window for treatment may be as long as 24 hours. And finally, even patients who are eligible for thrombolytics should receive, all patients who are eligible for thrombolytics, even if they may be a candidate for thrombectomy, should receive IV thrombolytics and then go on to have the mechanical thrombectomy procedure. So clinical research clearly demonstrates dramatic benefit from these treatments. For example, ischemic stroke patients who get thrombolytics are 30% more likely to leave the hospital, to have minimal or low levels of disability 3 months after treatment compared to those patients who did not receive treatment. And overall, the number needed to treat to achieve an excellent outcome is approximately 6 patients. Mechanical thrombectomy has even better potential outcomes, which is fantastic news because these patients typically present with much more severe stroke syndromes, don't typically get better with thrombolytics alone, and are likely to have very, very poor outcomes unless treatment is provided. And so in a meta-analysis of the mechanical thrombectomy trials that were completed in 2015, 40% of patients who were treated had reduced disability as a result of thrombectomy. And that includes about 1/4 of those patients having an independent living outcome within 3 months of treatment. The number needed to treat to achieve these excellent outcomes is only 1.3. And so there's really no room for doubt that any patient who is a potential candidate for thrombectomy needs to be taken to a center where thrombectomy is available as quickly as possible, and then be offered the opportunity to receive such treatment. The contraindications to thrombolytic therapy include, but are not limited to, recent or severe acute head trauma. So we wouldn't typically offer thrombolytics in a patient having a stroke as the result of say, an automobile accident. Those who have recently undergone either intracranial or intraspinal surgery, and that would typically be within the past 3 months. Although if you have the ability to communicate with the surgeon to talk about their risk of recurrent bleeding, you may be able to overcome that limitation. A history of intracranial hemorrhage is usually a contraindication, especially if the bleeding was not caused by something that has subsequently been fixed. Recent, meaning within the past 14 days, bleeding from the GI tract or ongoing GI gastrointestinal cancer. People who have poor clotting because of genetic disorders, those who've recently been treated with heparin, so within 24 hours. Also people taking oral blood thinning medications, so direct oral anticoagulants that we refer to as DOACs. If they've taken them within the last 24 hours, they're not going to be a candidate for thrombolytics. Warfarin is a bit more complex. If you know a patient's been taking warfarin but can show that their INR is less than 1.7, they would actually usually be a candidate for thrombolytic therapy. Any patient with known or suspected aortic arch dissection should not be treated with this medication. And then, of course, you can refer to our 2019 acute ischemic stroke guidelines from the American Heart and Stroke Associations for additional information. As an important note here, the ability of EMS providers to identify what medications the patient is taking, especially any anticoagulants such as DOACs or warfarin, getting history from the patient or bystanders or family about any current medical problems, and then making contact with the family to identify the time of onset of symptoms and making sure that they're available to provide additional history to the stroke providers in the hospital are amongst the most important tasks that our EMS providers have when taking care of a stroke patient in the field. So let's talk about what happens when the patient arrives to the hospital, protocols for stroke care in the hospital. So the goal of care is to reduce the amount of brain injury and thereby maximize the patient's probability of an excellent outcome. And so we refer to the stroke chain of survival, very much mimicking the chain of survival in trauma and heart attack, two other critically important time-sensitive emergencies, which link the actions taken by the patients and their family members to the healthcare professionals. These links include that the bystander, family member, or sometimes even the patient, though not very often, recognizes the signs and symptoms of stroke and understands that calling 911 is always the most important next step in the chain of survival. Next, EMS arrives on scene, rapidly assesses the patient and does a stroke assessment and a stroke severity, both helping to diagnose the stroke and also assess its severity. EMS then goes on to rapidly notify the receiving hospital that they'll be arriving with a stroke patient so that the hospital can activate their code stroke process, leading to more rapid diagnosis and treatment of the patient. To facilitate this, the Joint Commission and the American Heart Association have led the way in the development of certification programs for hospitals to identify the level of care available at a hospital and to assign specific metrics of performance to help understand the quality of care that's being delivered and to help those hospitals in their quality improvement missions. There are 4 categories of stroke hospitals that are recognized. They are the Acute Stroke Ready Hospital, the Primary Stroke Center, the Thrombectomy Capable Stroke Center, and finally, the Comprehensive Stroke Center. And you can find interactive maps for the locations of hospitals that carry these recognitions on the American Heart Association website or also through the Joint Commission. So let's review at a very high level what are the features of these different levels of hospitals. And the reason for doing this is that anybody who's interested in the development of a stroke system of care to better serve people within a given geographic region need to understand the performance metrics that are expected and available at the hospitals where they might be expected to deliver patients for acute stroke care. So an acute stroke ready hospital will typically serve to stabilize the patient and treat with IV thrombolytics as appropriate. And in most patients who are going on to have significant stroke symptoms or who have been treated with thrombolytics would then be transferred to the next appropriate level of care, which may be comprehensive thrombectomy capable or primary stroke center. These facilities very commonly rely on telestroke coverage, as neurologists are not often found in communities small enough to have acute stroke ready hospitals. The most common level of certification is the Primary Stroke Center, or PSC, which serve to stabilize stroke patients and provide IV thrombolytics. And then many primary stroke centers are able to admit patients whether or not they receive thrombolytics, but will also have in place transfer agreements with geographically nearby thrombectomy capable or comprehensive stroke centers if a higher level of intervention is necessary. Thrombectomy capable stroke centers are primary stroke centers which have also the ability to perform advanced imaging, which is necessary for identifying patients who will be eligible for mechanical thrombectomy for the treatment of LVO strokes. So these centers will have 24/7 coverage by neurology as well as neurointerventional radiology and typically neurosurgery as well, and can provide most of the services that are available at comprehensive stroke centers. This is the newest level of certification, and there are many fewer centers like this, but they are serving very important roles in areas that are currently underserved by comprehensive stroke centers. And finally, CSCs, or comprehensive stroke centers, have all of the abilities to take care of any and all stroke patients. They typically would be found at academic medical centers in large urban centers, and would have transfer relationships with TSCs, PSCs, and acute stroke ready hospitals throughout their geographic catchment. They typically will have residents and fellows on staff, and will be actively involved in clinical research, helping us to advance stroke care. This is an overview of the characteristics of the various facilities, and I just want to draw your attention to a couple things that are true. All levels of stroke, every hospital or emergency room that is capable of receiving a stroke patient must have a stroke team, which is typically a physician or ancillary provider, advanced practice provider, as well as nursing team that's available 24/7 to take care of stroke patients. They must also have 24/7 availability of at least non-contrast head CT or CAT scan, and they have to have the ability to administer IV thrombolytic therapy. So those are features of all stroke hospitals. And from there, we begin to diverge. So for example, a primary stroke center may be able to do advanced imaging and may be able to admit patients with hemorrhagic stroke or those who received thrombolytics. However, if a patient needs a mechanical thrombectomy or may be a candidate for mechanical thrombectomy, and they've arrived at either an acute stroke ready hospital or primary stroke center, they would typically be sent on to a thrombectomy capable or comprehensive stroke center. So this leads, understanding the characteristics of the different types of stroke centers is critically important to understanding how you would go about creating a stroke system of care that maximizes the probability that a patient in any given location within the geographic region being served has a reasonable probability of being able to access the best available stroke care. And this leads us to the policy recommendations that have come from the American Stroke Association, as well as many others with an interest in stroke in recent years. So we'll start first by understanding what is the role of EMS in the stroke chain of survival. First and foremost is to ensure that the patient is stable and can survive. So ABCs of EMS are airway, breathing, and circulation, with administration of oxygen as necessary. We then expect our EMS providers to perform a pre-hospital stroke assessment using an agreed upon stroke screening tool. Once it's established that the patient is likely to have had a stroke, we want to understand when the patient was last known normal or was observed to have the onset of symptoms. And this typically would involve talking to bystanders or family members. If possible, some history about what other medical conditions the patient may have, so that we can understand what their level of function is before the stroke began, because this can be very valuable in deciding what types of treatments may be most appropriate. A medication list, especially knowing whether this individual is taking blood thinning medications, is extremely important and may have an immediate effect on treatment decisions. Once this information has been gathered, is then our recommendation that the EMS provider contact the receiving hospital, or within our local system of care, EMS providers contact the stroke neurologist directly, review the information that I've just gone over, and then together the EMS provider and the receiving facility decide whether or not to activate code stroke. So code stroke is a key element that we'll talk about in a minute, but it's very, very important because it allows for things like the stroke neurologist to begin making their way to the emergency department, the CT scanner to be cleared to be ready to receive the patient, patient admissions being in the emergency department, ready to register the patient so that orders can be entered, lab ready to take blood to the lab so that we can get the ball rolling. And just anecdotally, at our facility, the implementation of this pre-hospital notification process within a period of just a couple of months reduced our door to needle time by nearly toward 20 minutes on average. So recommendations for EMS leaders who have an interest in the development of systems of care for stroke are to work in coordination with agencies locally, regionally, and on a statewide basis, to work with your medical authorities, so your emergency room directors, medical directors for stroke, and et cetera, and local experts to put together a triage program that takes into account all of the unique features of your geographic locale, to maximize the probability that patients will be transferred to the most appropriate facility, sometimes bypassing the nearest facility, using evidence-based techniques, which include standardized tools for stroke screening and stroke severity screening. So in the pre-hospital setting, a patient who is screened positive for stroke using a standardized pre-hospital stroke severity assessment tool that should be utilized to help identify, A, did the patient have a stroke or not? And B, is their stroke likely to be caused by a large vessel occlusion, which are two key pieces of information in making decisions about whether to take the patient to the nearest hospital, the nearest stroke-ready hospital, or the nearest hospital that can provide advanced levels of care. And we'll go over some of the recommended policies that can help an EMS provider make these decisions in real time. So these procedures, so the most effective pre-hospital procedures are used to identify patients who are not eligible for thrombolytics, but could be candidates for mechanical thrombectomy, because this is the situation in which, if the patient's not going to get IV TPA, there's no significant benefit to taking them to the nearest hospital, especially if that hospital is not able to perform mechanical thrombectomy. So if you're outside the window for IV thrombolytics, but you definitely have a stroke, and that stroke might be a large vessel occlusion stroke, then it makes sense in most cases to bypass any facility unable to provide mechanical thrombectomy. So that concern forms the basis of this special report from our consensus statement from the American Academy of Neurology, Heart Association, Stroke Association, and a number of others who are with a strong interest in acute stroke care, that was published, I believe this is in 2019. And we're going to review in a little bit of detail the general principles of this consensus statement. First and foremost, it's critical to develop destination plans. The destination plans are take a number of different geographical factors as well as community standards into account, and have to include things like traffic patterns, the type of treatment that's available at any given facility, and should take into account things like how well those individual facilities meet specific metrics like door to needle times, door in, door out times, whether or not they are able to do mechanical thrombectomy, and if so, how often, and then how quickly are they able to diagnose and treat stroke patients, either with thrombolytics or mechanical thrombectomy. So these are important features that need to be taken into account when making decisions about whether to go to the nearest facility or to bypass and go to a higher level of care. And these regional destination plans need to take into account whether patients are eligible for thrombolytics, whether they have large vessel occlusion stroke, what the time of onset is. Is it less than 3 hours, less than 4.5 hours, less than 24 hours? And is it possible to get the patient to the highest level of care? And would doing so jeopardizes the patient's ability to get timely treatment with thrombolytics if appropriate. So I said a mouthful there, and I'm going to review this again on a case-by-case basis, depending on what your geographic region looks like. In general, however, the most important thing is getting rapid access to the most appropriate level of care. So this regional stroke system needs to ensure that rapid access is available both in the pre-hospital setting and during the hospital phases of care. And so in places where there's more than one stroke center available, sometimes it makes more sense to go to a hospital that's a little bit more distant in order to ensure that the right care is available to the patient. And in order to make these decisions in real time, it's critically important that the EMS provider in the field not be left to their own devices, but rather there should be an ongoing triage system of care that takes into account all of the features that we've described about the hospitals within the catchment, and be actively engaged in a quality improvement program, as well as coordinating data on a system-wide basis so that decisions about how to dispatch, triage, and transport patients are made with the intention to achieve the best possible outcome, but using real data in real time. So these are significant challenges that shouldn't be left to the individual EMS provider in the field, but should be part of an engaged pre-hospital system whereby the EMS provider has access to experts who understand the system of care on a regional basis and can help make these triage decisions that can be quite daunting. So the consensus statement went through in some detail how you might design a system of care depending on your geographic setting. So the rural recommendations, which we've taken into account for the Wyoming Telestroke Network, kind of follows the following pattern. So if a large vessel occlusion stroke is not suspected, then it is appropriate to transport the patient to the nearest stroke center, be it a primary stroke center or acute stroke-ready hospital. And this is especially true if the patient is a candidate for IV thrombolytics. So get to the nearest hospital that can do a CT scan and can administer IV TPA. If an LVO is suspected, then the goal is to get the patient to a comprehensive or thrombectomy-capable center as quickly as possible. So if the transport time is less than 60 minutes from where the patient is, then you should take them to that center. If it's more than 60 minutes, there may be benefit to first stopping at a primary stroke center, unless getting to the primary stroke center would be more than 30 minutes from where they are. So you can see there's some numbers to take into account here. Does it take 60 minutes to get to the highest level of care? If not, go there. If it's less than 60 minutes, but more than 30 minutes more to get to the primary stroke center, you should still go to the highest level of care and bypass the nearest center. So remember those numbers, 30 and 60, because now when we move into the suburban setting, it's the same triage protocol, but the numbers are now 45 minutes and 30 minutes. And then finally, when we're in an urban setting, the numbers drop to 30 minutes. So just to recap, if an LVO is not suspected, take the patient to the nearest center that can do a CAT scan and can give IV thrombolytics. If an LVO is suspected, take the patient to the highest level of care that is not so far beyond the nearest center that it would jeopardize the patient's safety. That's the way I would summarize that. And it's important that each individual stroke system or geographic region look carefully at their transfer times, as well as the capabilities of the hospitals within their organization, and then try to build a geographically specific triage system that takes these kinds of recommendations into account. Okay, so we've talked about the importance of pre-hospital recognition of stroke, the value of getting to the right center in the quickest possible time, and the type of care that's available. So let's talk now about what is the role of the EMS provider in evaluating the stroke patient and what tools are available to them. So firstly, we need to enable our EMS providers to recognize stroke. So we strongly recommend that a validated stroke screening scale be used. We don't have any specific recommendations about which one, though several have been validated. And we do recommend that any given system of care try to reach an agreement about using a single stroke screening tool so that we're all talking the same language as we talk about patients and try to make very fast decisions in real time. So the screening scale is going to either rule in or rule out stroke in the field. And if a stroke is not likely, then you treat the patient as any other emergency and take them to the nearest appropriate emergency department. If the screening scale is positive, then we need to screen that patient for the possibility of large vessel occlusion stroke using a stroke severity scale. If an LVO stroke is likely or possible, then the patient should be taken to the nearest appropriate facility using the recommended protocols that we just reviewed. And if an LVO stroke is not likely, then the patient should be taken to the closest stroke center. So again, we need to have tools on the ready for our EMS providers to both screen for stroke, yes or no, and then if yes, screen for stroke severity so that they're enabled to make appropriate triage decisions for transport. So stroke assessment tools are needed for EMS providers to identify stroke quickly, and then also to make sure that they're transferring to the appropriate center. Stroke screening tools should be simple and generate a binary result. Either a stroke is suspected or a stroke is not suspected. And then there's pretty clear evidence that the use of such tools increases the accuracy of stroke identification by EMS providers. For example, one study showed that paramedics increased their overall sensitivity for stroke from around 60% to around 90% with training in a specific stroke screening tool. So there are multiple tools available, and we don't recommend one versus another. There are a number of randomized controlled trials ongoing now, which hopefully will give us some answers. However, the most widely used stroke screening tool is the Cincinnati Pre-Hospital Stroke Scale. Other validated stroke tools include the Los Angeles Pre-Hospital Stroke Screen, the FAST, which is the same that we teach the lay public, and then the Miami Emergency Neurologic Deficit Scale, or MENDS. So the Cincinnati Pre-Hospital Stroke Scale, which to my eye looks very much like the FAST scale, asks you to tells you to ask the patient to smile and show their teeth, looking for facial droop or facial asymmetry. Have them hold their arms aloft for 10 seconds with their eyes closed, looking for one arm not moving like the other, and then asking them to repeat a simple phrase like you can't teach an old dog new tricks, looking for slurred speech or inability to speak or follow commands. If one of those signs is abnormal, the probability of stroke is about 3/4. And if all three are present, the probability of stroke is in excess of 85%. The FAST exam, which again looks very much like the Cincinnati Pre-Hospital Scale, is face drooping, arm weakness, difficulty speaking. If any of those things are abnormal, it's time to call 911, FAST. Okay, stroke severity scales are used to quantify neurologic deficits. The best known one is the NIH Stroke Scale Score, which is decidedly too long and cumbersome to be done in the field. And so for many years, people have been looking for ways to abbreviate the NIH Stroke Scale Score and not give up any of its sensitivity for stroke, and to make sure that it's adequately powered to make it very likely that you'll identify a large vessel occlusion stroke, or actually also a hemorrhagic stroke if present. Again, it is highly recommended that any given EMS region decide together which of these severity scales are going to use and put into place quality improvement metrics to monitor adherence and usage of the stroke severity tool, and then also evaluate the accuracy of that tool in retrospective analyses. There are multiple examples that we can mention here, including the Cincinnati Triage Assessment Tool, CSTAT, facial palsy, arm weakness, speech changes, time, eye deviation and denial or neglect, which is called the FAST-ED, the Rapid Arterial Occlusion Evolution Scale, or RACE, the Los Angeles Motor Scale, or LAMS, and then finally Vision, Aphasia, and Neglect, or VAN scale. So I'm not going to go through these in any detail, but please understand these are each very rapidly done. So for example, the The CSTAT involves doing the Cincinnati pre-hospital stroke screen with the addition of asking the patient to follow your finger from one side to the other. So it is a tool that takes no more than a few moments to administer, and all of them have a pretty high sensitivity and reasonably good specificity for large vessel occlusion stroke. So pre-hospital notification, this is the heart of everything that we're talking about here. The whole point of a EMS system of care, beyond recognizing the stroke and evaluating its severity, is making sure that you're taking the patient to the right hospital, and that hospital has taken the appropriate steps to take care of your patient in the most timely manner possible. And pre-hospital notification is a critical element to this, and something that we pay tremendous attention to within our own system of care. So EMS professionals should notify hospital staff that a stroke patient is coming prior to arriving to the hospital. This improves the quickness with which the hospital can triage and evaluate the patient, and leads to faster diagnosis and treatment times. The sooner the patient gets medical treatment, the greater the potential for outcome. So some studies, for example, showed that there's an increase in the percentage of patients with door-to-imaging times of less than 25 minutes when there was a pre-hospital notification system in place. We also saw decreased onset to door time. So in other words, patients actually got to the hospital more quickly when pre-notification systems were enabled. Overall, pre-hospital notification led to much more rapid triage, evaluation, and treatment of patients with acute ischemic stroke, and is something that you, if it's not present in your facility, is something you should absolutely be pushing for. So in conclusion, stroke is treatable. It's a tremendous societal burden, but treatments are evolving all the time, but they are all time sensitive, and time is brain. And so the point of our conversation today is to enable our pre-hospital providers to recognize stroke quickly, evaluate the severity of that stroke, and then use that information within the context of a well-established and constantly improving regional system of care for stroke, one that's focused on the stroke chain of survival, to increase the probability that patients will be delivered to the hospital best able to provide care, following the stroke transport protocol for the area to determine the best destination, and giving advance notification to that receiving hospital. And just as a reminder, sometimes the best destination for your patient is not the same as the closest destination.
Dr. Willard,
I'm here.
thank you very, very much. We appreciate the time you took today. So we have a question from one of our attendees, and I think she was concerning the LVO assessments that you were talking about earlier in your presentation. She's asking, which specific LVO assessment do you recommend or do you prefer?
So of the ones that we mentioned, we do not yet have any data to suggest. All have been shown to have reasonable sensitivity and specificity to be useful, but we don't have any completed clinical trials comparing one to the other. And so based on that, my recommendation has been to use the one that's simplest to use. And in my opinion, that's the CSTAT. So I've recommended that for use within our local region. But I also I'm a participant in a stroke system of care that covers a very wide geographic region with a large number of EMS services that I have more or less influence over. And so we have not at this point standardized the approach within our system of care. And there are we have EMS providers who've made, I think, a very cogent argument that sometimes tools that are a little bit more complex, but have, say, digital tools associated with them to facilitate the evaluation of the patient. Like, for example, Stroke Van is another of the tools we mentioned, has a very nice app that allows or enables the rapid assessment of a patient and then creates a stroke severity score that is easily shared. So this is a moving target. American Stroke Association has not taken a position in this, and I also don't have a strong opinion. I think the most important thing for an EMS provider is to use one, be very familiar with it, and then be able to communicate clearly the findings of your severity assessment to your local facility when you're making your pre-hospital notification.
Thank you, very helpful. And the attendee has said that they are using Van and they have been had good luck with it.
Right. I've heard the same from many people, and I'm friends with the developer of that tool, and it's got some very cool features, and the app is really pretty spectacular.
We have another question that has just come in. It says, we use CSC to determine if the patient's having a stroke and the MEND to determine if the patient has had a possible elbow. Seems like CSC and MEND is for determining a stroke, and we should use another scale for determining elbow. I'm not familiar with MEND.
Yeah, I think it was mentioned. Let me pull it up again real quick if I could. If I can get back to my screen share. Go back a little bit. So yeah, you're right. So MENDS is an assessment for whether a stroke is present or not. And these are some of the recommended stroke severity tools that we might consider. I'm also not totally familiar with MENDS, and so I can't say how much more you would need to add to it. But generally speaking, when you're trying to determine whether a large vessel occlusion stroke is likely or not, the parts that are missing from the stroke screening tools typically have to do with cortical function. And so, for example, gaze deviation or neglect syndrome are two things that are missing from stroke screening tools, which are typically included in stroke severity tools that increase the sensitivity for elbow. And so if you're doing MENDS, if you added, and maybe it's already in there, I'm not for sure, but if you added eye movement and sensory neglect to that scale, then you would probably have something that's reasonably similar to these stroke severity scales that we're talking about.
Thank you. And I'll let our participant that asked that question let us know if that answered it for you. And while that's happening, if anyone else has questions right now, please go ahead and enter those in the chat. Dr. Wheeler, I'm curious, with the introduction of the rural stroke programs that are coming out and Connect a Place becoming more commonplace, where do you see stroke systems of care going in the next 5 or so years?
Yeah, so my hope is that we'll see the continued development of integrated telestroke networks to cover these rural settings, so that every acute stroke ready hospital has very rapid access to stroke experts. And that we continue the process of improving transfer arrangements so that patients who, say, are in smaller communities having large vessel occlusion strokes, it's understood on the front end that they're probably not going to go to their home facility, but maybe life flighted even, from their neighborhood school to the nearest thrombectomy capable center, which is something that does happen sometimes here in Wyoming. The advancements in thrombolytic care to include the use of tenecteplase in favor of TPA is definitely spreading very quickly. We don't yet have FDA approval for such treatment, and so this is it's important to say that this is an off-label question, but there are a number of stroke systems and large stroke centers around the country that have switched completely to tenecteplase. My anecdotal experience is that we have identified a very significant reduction in door to needle time since we made the switch. At the time of the switch, our average door to needle time was right at 30 minutes, and with the switch, we're getting closer to 20 minutes average door to needle time. Our spoke sites throughout our telestroke network have not yet adopted Tenecta-Place. But as we gain more experience and more comfort with this treatment, and particularly if, as we expect, it becomes part of guidelines-based recommendations from American Stroke Association and/or receives FDA approval, I would expect really a complete switch to Tenecta-Place, barring some unexpected, clinical trials results in the coming year or two. So I think it's an important change, and really just as a reflection of the constant evolution of stroke care, leading to greater and greater reductions in the time from symptom onset to the time of revascularization or definitive treatment.
Thank you. This has been very interesting, and we appreciate the engagement from our audience today. And again, as well, thank you, Dr. Wheeler, for your time and preparation for today. With that, we are approaching 1:30 p.m. Central Time, so we are about out of time today. Appreciate everyone taking the time. And again, those slides, recording, and certificates will be available in the next 2 weeks via email. Thank you all again, and have a wonderful day.
Thank you. Bye.